Hello, I'm Dr. Durban. I'm a neurologist and headache fellow at the Detroit Medical Center and the VA in Detroit. And today I'm going to talk a little bit about the brain pain mood connection. And the specific question I wanted to address is why would mental health care help when my depression is caused by my headaches? So these are all questions and reactions we sometimes hear in the office, in the neurology office. They're all very reasonable thoughts. Um, if you're living with migraines, up to, 15, 20 headaches days in a month, of course your mood will suffer from that. But a couple of these thoughts assume a linear model of migraines cause depression. And the evidence doesn't really support a linear model like that. It supports more of a bidirectional link between mood and migraines. And we'll talk a little bit more about that throughout the presentation. So, depression is very common in people who have migraines. The numbers, the number of depression diagnoses are significantly higher in migraine patients than in the general population. People with migraines approximately twice as likely to experience depression, and this risk increases with the frequency of headache days. So, if we look at chronic migraines versus episodic migraines, chronic is more than 15 headache days over the course of a month, and episodic is less than that. And depression is more common in those who have the chronic migraines. Individuals who have both migraine and depression, they often report lower quality of life, higher disability scores, and more healthcare utilization. Anxiety is even more common than depression in people with migraines, with up to 50% of people experiencing it. And just as a side note, the World Health Organization actually ranks migraine amongst the leading causes of disability worldwide. So we talked a bit about this bidirectional relationship between mood and migraine. So what is that? Um, so it's basically means that each disorder increases the risk of the other disorder. And worsening in one of them, either migraine or depression, PTSD, insomnia, will worsen the other. And it kind of goes around in a circle that way. Um, so essentially, depression can cause and be caused by migraines, suggesting that they share underlying mechanisms. Studies show that people with migraine are at increased risk of developing depression. People with depression are at increased risk of developing chronic migraine, which is migraines more than 15 days in a month. And anxiety can predict potential medication overuse, which is linked to rebound headaches in people with migraines. So we're going to look at why these um, these disorders are linked. Part of the reason why is that there's an underlying shared neurochemistry between them. So these are examples of neurotransmitters that are involved in both disorders. Serotonin and norepinephrine, they're known to regulate pain inhibition, mood, stability, sleep, stress response, and they're involved in both. Dopamine, the reward system is also involved. The HPA, hypothalamic pituitary adrenal axis, which includes ACTH, cortisol, modulate the stress response as well. And then things like CGRP signaling. So this little protein, which is more migraine specific, but it is actually modulated by stress. So all of these underlying neurotransmitters and peptides are can affect both migraines and mood disorders. There are also shared neural networks, so shared underlying anatomy. When they did studies, the functional MRIs showed on imaging that there is some overlap in the brain regions involved in both migraines and depression. So some examples of that are the amygdala, the anterior cingulate cortex. Both of these are part of the limbic system. And in both conditions, you have increased limbic activity. So these are critical for emotional regulation, pain modulation. There is also reduced prefrontal cortex regulation seen in both. And the insula is also involved, and some of the brainstem nuclei, particularly those that secrete the neurotransmitters we talked about in the previous slide. Chronic pain rewires the brain. So when the pain becomes chronic, the nervous system tends to become sensitized, and the brain essentially becomes more efficient at producing pain. So you have reduced gray matter in the prefrontal cortex, altered thalamus connectivity, so it becomes more sensitive to any sensory inputs, and you have overall increased central sensitization. And this leads to an increase in the pain response where non-painful stimuli, non-painful sensory inputs can actually become painful, which is called allodynia. So in addition to that, depression lowers pain threshold. So all of this leads to increased pain response. So depression can cause what's called chronification of attacks, which is the transition from episodic migraines to chronic migraines. And again, episodic is less than 15 headache days in a month, and chronic is 15 or more headache days in a month. Depression lowers pain threshold. It increases migraine attack frequency. It causes higher perceived pain intensity. And it also is linked to poorer response to preventive medications and increased risk of over-the-counter or pain medication overuse. And this can lead to this vicious cycle. If we only treat one part of this cycle, the rest continues to drive the symptoms. So someone with migraine may have sleep disruptions from the pain. This can lead to fatigue, social isolation, which can worsen anxiety, depression, and in turn increases pain sensitivity, which leads to increased severity in the migraines, and so on and so forth. So back to one of the initial questions that we started with, why are you referring me to therapy? So we'll talk a little bit about behavioral therapy and migraine. CBT, which stands for cognitive behavioral therapy, and other behavioral interventions show 30 to 50% reduction in headache frequency in some randomized controlled trials, improved headache disability scores, MIDAS and HIT-6, and also sustained benefit on follow-up. CBT actually shows similar numbers to some of the classic preventive medications, um, but the best results overall are seen with a combined approach of utilizing medications with added behavioral therapy. So behavioral therapy is considered is a guideline-supported migraine treatment. So here are the two questions that we aim to answer here. Does treating depression improve migraine? So while there is no current evidence that treating your depression helps control migraines, we know that it's important to treat depression in people with migraines because depression leads to the chronification of migraines, so having an increased number of headache days. So it's important to treat that depression to keep that number as low as we can. Evidence supports that treating depression reduces headache frequency, improves disability scores, and leads to better adherence to medications. Now, does treating migraine alone resolve depression? Well, migraine reduction does improve mood in general, but it's important to realize that depression often persists if it's not directly treated. So treating migraine alone does not completely resolve depression typically. So combined treatment of migraine and depression generally yields the best outcomes. Just a note that there is medication overlap between depression and migraines. Um, and this kind of supports the previous slides where we were talking about shared circuitry and shared chemistry. So antidepressants sometimes are used in migraine prevention. Some of the most common ones are tricyclic antidepressants, such as amitriptyline, nortriptyline, um, or SNRIs, which are serotonin norepinephrine reuptake inhibitors, such as venlafaxine or duloxetine. So these medications target serotonin and norepinephrine, which, as we spoke about earlier, are part of the shared pathways between mood and migraine. So we use these for treatment of both, although it's true that the dosing varies between treatment of migraine and treatment of depression. A word about the effect of sleep and anxiety in migraine. So insomnia has been shown to double migraine risk. This is a big trigger for migraines. And treating insomnia alone can reduce the frequency of migraines. And we also know that depression disrupts sleep architecture. Um, So there's a connection there. And anxiety predicts chronic daily headaches, and treating anxiety can uh, reduce the severity of headache attacks. And it's been shown that improvement in sleep restoration can improve headache control. There's also a link with the stress system and previous trauma. So chronic migraine populations show higher risk rates of PTSD, elevated ACE scores, which are adverse childhood experiences, and autonomic hyperreactivity, or increased in fight or flight mode. Um, this is because trauma sensitizes the stress response system, and that system overlaps with migraine circuitry. So it makes sense that people who have experienced a lot of trauma and have these elevated scores um, tend to have more migraines. If my headaches improve, my depression will too. So this is sometimes true, as we covered a little bit earlier, but it's often incomplete. Reducing headache days improves mood, but there is an underlying depressive circuit that may persist unless it's directly treated. So it's important to treat depression thoroughly and not just assume that when the headaches go away, the depression will automatically go away. And this is why integrated care works best. Integrated care means neurological care in association with mental health care. When patients are able to have all of those components addressed, it reduces disability scores, improves their work productivity, lowers their healthcare utilization, and decreases medication overuse. So this is just an example of what therapy can do in the brain and how it helps these circuits that we were talking about earlier. So cognitive behavioral therapy can increase or improve prefrontal cortex activation for better regulation, decrease amygdala reactivity, improve connectivity, and therefore enhance pain modulation. So, who benefits most from integrated care? Typically, people with chronic migraines, more than 15 headache days a month, people with high disability scores, people with comorbid anxiety, people with medication overuse, or if there is a poor response to monotherapy, so one medication or one therapeutic modality. What mental health is not, it is not saying that someone's pain is imaginary, and it's not replacing neurologic care. It's also not blaming the patient. It's about expanding the treatment team and trying to tackle the migraines and depression from all different angles. Treating mood will raise pain threshold, improve the response of preventive medications, reduces the risk of chronification, so increased frequency of headaches, and improves resilience to pain. So treating mood modifies the migraine trajectory of a patient. So, in conclusion, migraine and depression share neural circuitry, anatomy, neurotransmitters. The integrated treatment approach improves outcomes for both, and addressing mood is neurologic care. So, your migraine is real, your depression is real, and they are connected. And when we treat both, outcomes improve. Thank you for your time.